drug for a patient, is that because you do some sort of molecular investigation of their DNA or something where that drug might work better with that type of DNA?
No. So it's particularly usually just based on other medical conditions. So whether, you know, if you've got somebody who's already got diabetes and a high blood pressure and you're worried about sort of vascular events anyway, then you know, you may not choose a drug where you're worried that it may cause vascular events. That SoCal score that I was talking about at the start can be somewhat guiding in that if you've got a low SoCal score, then you seem to do pretty well no matter what medicine you use, whereas if you've got a higher SoCal score, then the more potent medicines may be better, but again, only if you can tolerate them without the worrying side effects that I was speaking about. So, you know,
maybe in time they might be able to do a blood test to match that? Or?
No, I don't think so, because as I was saying before, there's really, if you look for mutations and things right at the start, they're sort of not there. So, yeah, there's not really. They may be. So as we look, there's certainly some evidence that there are other ways of looking for those mutations which are more sensitive. You know, so as we get better and better technology to detect those mutations, we may detect that with the better technology we can find mutations at diagnosis, which would then guide us to use particular drugs. But no, at the current stage of the game, then it's largely based on a decision to, you know, as to what's best for you based on other medical history, conditions and things. As I said, there are certain levels that we worry about at certain times, and this sort of 10% cutoff at 3 months is coming out as being a sort of a fairly critical time point that we can use, which is only 3 months into treatment. So it's sort of you know, you're not waiting for years down the track to know how things are going to happen, and it can guide us as to whether we sort of think you're fine or whether we're a bit worried about things because it's greater than 10%, and that's sort of based on stuff like this. So this is again the trial of nilotinib versus Gleevec, showing the orange curve were people who had who still had more than 10% BCR-ABL at 3 months, just showing that both with nilotinib and Gleevec, that about 20% of those patients progressed versus not many of the other patients at all. And so, you know, that 3 month level can be very useful in sort of determining how you go. You can see that the outcome was actually similar. So, you know, about 80% with both drugs. Ignore that last little drop here, but the actual figure is 80% versus 78%. But the difference is that there's more people who don't get to that threshold with Gleevec versus nilotinib. So again, these newer drugs are better at getting you down quickly, but as I said, none of the new drugs have shown any survival benefit. So so you know, there's no proven benefit in terms of survival. This is all just looking at, you know, levels at this stage, and as I said, there's concerns that may lead us to choose one drug over another. If you then do progress or have an inadequate response based on those sort of tables that we look at, then yes, then there's a few things we might do. So there may be a role for drug level testing. At the moment, that's really only available and only in very selected centres for Gleevec, as opposed to nilotinib and dasatinib. There's some data coming with nilotinib and dasatinib, and so we may be testing for drug levels in the future, but there's not a whole lot of ability to do that at the moment. Mutation testing we've spoken about, so certainly at the time when you are progressing, you know, or failing to meet those endpoints, then that's a time where we often would do mutation testing and see whether there's any particular mutation which would steer us in favour of one treatment or another, and then often would think about switching to an alternative drug, although as I said, really there's not much to guide us in terms of which alternative drug to use or whether that's the right thing to do. obviously we'd love to have great data on quality of life of the different drugs and be able to tell you, oh look, this drug's great because you feel fantastic on it, and this drug people don't feel quite so good on it. But it's been a sort of a thing that's been lagging behind in the trials. They've come up with a quality of life questionnaire which is specific for CML, but really we don't have a lot of good comparative data to say that people on Gleevec feel fantastic, whereas people on dasatinib feel dreadful, or vice versa. So we really don't have that. We've only got our own personal experiences in talking to patients to sort of guide us in that regard. And so then we get to the point about whether we can ever stop these things in future. And so there are. So as I mentioned before, MR 4.5 is what we sort of now call complete molecular remission, if you like. So this is a level that we think we get to where essentially the disease is undetectable based on average assays, but it depends on how good your assay is. And you can see that this is just one example again, that nilotinib versus imatinib. It seems that more people get to that very low level on nilotinib, and similarly with dasatinib as well. Oh, sorry, I've got another slide. So this is the dasatinib slide. This is an earlier time point, so don't compare the actual figures to the last one. But again, just seem to get you to that very deep level a bit more often. The importance of that deep level is if you do get to a complete molecular response, and you stay in a complete molecular response for at least 2 years, then that would have made you eligible for one of these two trials. So the trial on the left is a French trial of about 100 patients. The trial on the right is an Australian trial of about 35 patients. So we're talking very small numbers of patients around the world at this stage. But so what these trials did is, after people had been in remission in complete molecular remission, as in undetectable disease, for at least 2 years, and had been on treatment for at least 3 years, then they had the drug stopped, and they were watched very closely with monthly blood tests, monthly, not just full blood, not just blood counts, but the actual CML levels every month, and then had their treatment restarted if it looked like those levels were rising up. But if it didn't look like those levels rising up, then they just continued to be watched. And so they had monthly levels for a year, 2 monthly levels for another year, and then 3 monthly levels indefinitely. And in that group of patients, about 40% were able to stay off the drug. So 60% of people relapsed and needed to go back on their drug. It seemed that all of those people went back into the same level of remission that they'd been in before, but 40% didn't need to be on the drug. And so there are patients on these trials who are now out at 8, 9 years down the track who are still off their drug and haven't needed to restart Gleevec. And so there is that potential ability to go off the drug, but only in that very select group of people who are in that complete molecular remission for at least 2 years. So those trials have stopped. There are other trials around the world and even Australia with stopping drugs. This is then another trial, again, just looking at what happens if you stop one of the newer drugs, nilotinib or dasatinib, and again seems to be probably as good as Gleevec. This looks higher than Gleevec, but it's because of the sort of variances in how they ran the trial, not necessarily variations in how good it is once you stop. And so it probably around about 40 to 50% of people will be able to stop these drugs and not have to take them again if you can get down to that low level. But there's not a lot of, well, probably the majority of people still don't get down to that low level, or certainly take many, many years to do it. And so, even in the best case scenario on those slides I showed before, about 50% of people at about 5 years will have achieved the low level, and then you need to be in that low level for another 2 years. So, you are talking usually for most patients many years down the track if they're going to achieve it at all. And so I guess that's the key point, is that we know that if people stop their drugs before they get to that level, everybody relapses very, very quickly. And so, you know, we have people who've stopped their drugs for a variety of reasons before that very deep, sustained response, and everybody relapses early. So it's not the sort of thing to try on your own, if you like. I do have patients that I've tried this in off trial, but only in that very specific circumstance where they get to.
So it turns off that mutation. It must turn off that mutation.
So you can actually detect the mutation in the majority of people if you use really sensitive testing. So it's not just turning off the mutation. It's probably something to do with. There's a few different theories, but it may do something to your immune system, where your immune system wakes up and starts to sort of keep track of things. But it probably more likely it's just got to do with the fact that the CML arises from its own leukemia stem cell, if you like, and so most of the cells that you're detecting in CML are sort of daughters of this leukemia, these very few numbers of leukemia stem cells, and if you're on treatment for a long enough, to a deep enough level, you just exhaust the supply of these leukemia stem cells, and so the disease can't divide anymore. Even though you can detect it, it's not at a level where it can divide out of control anymore. That's sort of one of the theories. Well, no. So that gene is. Oh, you mean to test the normal population, or to set? Yeah. Yeah. No. So it's a mutation which occurs. Sort of out of the blue, if you like. We don't really know much in the way of what determines it. It's not one. So the breast cancer one that you're talking about is one that's actually tends to be passed on from one person to another, or at least the susceptibility to get the mutation is passed on from one person to another. Whereas for CML, the mutation that occurs in your bone marrow seems to be a random event, and so there doesn't seem to be CML that runs in families, and so you'd have to screen the whole population. And the problem is that they have actually found that mutation in normal people, and so it may be that you know those people have then maybe got. They've had the mutation, but it hasn't gotten around their immune system or something like that. So in small numbers of normal people, you can detect the mutation. So what does detecting it mean? So yes, generally we wouldn't test normal people for it. As I mentioned, there's some other drugs that are around. So Bosutinib is another TKI. It's actually licensed for use in Australia. It's got TGA listing, but it's not reimbursed on the PBS. But it may be coming on the PBS in future years. Ponatinib is a drug which is good because it's the one that it's the only one that looks at this particular mutation, this 315I mutation, which occurs in that fusion protein. So if you've got that, then really Ponatinib's about the only drug that we've got that we know works. The issue with Ponatinib is one of more of access at the moment. It's sort of not really licensed in Australia. You can get it, but it costs, you have to pay for it essentially. Sorry? So the company has to put it up for TGA registration. So it's the company that's actually got to do the initial application to have it in. But you can bring any drug into Australia. You just need to then go through different pathways. But it's more than you have to pay for it. So yes, you can get it, but you have to. There is actually a company who are not the company that make the drug, but another company that are importing it into Australia. So you can get it, but I can't remember. I can't tell you what it costs. But like all these things, it's $60,000, $100,000 a year, that sort of thing. Yeah. And then as I mentioned, we are heading into trials of combination therapy of interferon, and nilotinib is one Australian trial that's about to open to see if perhaps that can lead us to more patients getting deeper responses or less patients getting shallow responses, and we'll see how that goes. There's some suggestion that may be the case, but interferon's a tough drug to take, as I showed at the start, and so it may be that not many people actually tolerate the combination.
Would they do the same dosage of
It's a different dose. It's pegylated interferon, which is sort of a long-acting interferon. And yes, no, smaller doses comparatively to what they would have used when interferon was used on its own previously. Yep. And then just really 2 quick slides about what happens if you don't have chronic phase, if you've got accelerated phase. It does depend on whether you've just got accelerated phase or whether you've got other things. So yeah, you can get clonal evolution means that as well as the Philadelphia chromosome abnormality, you've got other mutations as well. And so if you've got accelerated phase looking down the microscope and also other mutations, then you don't tend to do as well. You tend to progress, and those patients we'd often consider for bone marrow transplants or other therapies. And certainly blast crisis is, as I said, a sort of an aggressive acute leukemia, which is often hard to get patients into remission with, but if we do get them into remission with and they're young enough to have a bone marrow transplant, then certainly the bone marrow transplant would be the sort of the first option in that situation. So in summary, CML can be controlled with tyrosine kinase inhibitors in the vast majority of people. The choice of which one you use depends on, as I said, on other medical conditions and perhaps some assessment of a patient's risk from both that medical conditions and the disease. And then there is some suggestion that long and deep remissions may lead to the ability to try and cease the drugs in future.